Okay, so it's tough to argue with Tirachan and Mipo, I know, but I'm also a plater. I've done plating same as Tirachan more than 15 years. We were the first one in Asia to start using LCP, and we like it so much. But in recent 3 or 4 years, we've changed about 2/3 of our cases we managed to do with the nailing, and I can tell you why. I think first about the implant developments, the indications, and some of the case examples. This is the first type of nailing. It's not a good device, as you can see. They use very similarly. The analogy is always to the hip. Okay, so when the hip got a spiral blade, then they think about putting it in the humerus. And as you can see, the early designs, they all based on the concept of avoiding the articular surface. So they all insert at the junction between the articular surface and the greater tuberosity, and they always go through the avascular area of the rotator cuff. And that's why they always produces ischemia at the rotator cuff and a tremendous amount of pain. And that's why I hate nailing, I have to say. When I first started doing nailing in the first part of my career, I hate it because my patients, they all have severe pain. Look at the previous approach is the anterolateral approach, very similarly. But nowadays, what we advise is a more medial approach with a central placement of the nail. And as you can see, the previous entry sites. The lateral entry sites, similar to a hip, when we put in a gamma nail or a PFNA, we always now want to go for a slightly more medial, because we know if you inserted two lateral entry point, you tilt the head into a varus, and then you have a problem, similarly like this. In the past, we used joysticks to avoid malalignment, and this, as you can see, people can use 2 K-wires to use as joysticks to bring the head, to tilt the head into a more valgus position. But nowadays, when we try to use the nail, I always use also like an intrafocal pinning, like in the distal radius, through the neck fracture, and then I bend it, and then I can have a more medial or central entry point over here. Again, similar to all kinds of nailing, you need to get the correct entry point. Why a lot of people have a poor result with nailing? They don't have a good entry point. Getting the good entry point, I would say, give you already achieve half of the surgery because you get it right. Why am I choosing some of the cases to nailing? Because I think this makes a lot of sense. When we take a look at the bone density across the humerus, we know that there are areas that there has dense bone. Usually it's the subchondral, the superior subchondral region where you have a densest bone. And when we try over the neck region and in the center, it is actually not much bone. Those who have done plating, we all know why sometimes it's so difficult to control the head tilting into varus is because all the screws putting it from the lateral position doesn't engage the strongest bone. And that's why there is a tendency for the head to tilt into varus. The newer designs, both many companies have this, but this newer designs, they are all straight or relatively straight. And as you can see, the entry point that goes through the more central part of the humeral head, and that area has a very dense bone. This is the area where you have a very, very dense bone. They also have some designs that you may increase the purchase in the humeral head, although I think I don't particularly find it very useful for this so-called screw-in-screw design in my hands. And the same, for the Mipo, you do the sutures to attach the tuberosities to the head. And for the nail, again, it's the same. We place the sutures to tie it in the insertion of the supraspinatus, infraspinatus, and all these we can tie it together before you insert the nail. For simple case, I think the nailing is the best. For example, like this one. You can choose all kinds of device. You can choose a casting even for this fracture, for example. It was one of the very first few cases that we did a nailing, and as we see, very minimal. I mean, the entry point is the most important because there is no fracture here. The entry point is very easy to find. The difficult part is if you have a fracture proximally, then you have a problem. So this is correct. When you do see some piece of cartilage there and a nice piece of subchondral bone, this is the subchondral bone we talk about. We don't see it when we insert a screw from the lateral aspects. And with this, we can achieve very amazing results. This was the clinical result only at 2 weeks' time. 2 weeks' time. One of my visiting fellow was so amazed because just at 2 weeks' time, the patient can do all sorts of activities with no pain. So he really took a picture for this. 5 months, the proximal humeral shaft fracture heals nicely. You may say, I mean, that's why for simpler fractures, extra-articular, for the two-part fractures, I prefer the nailing. Similarly, in the more osteoporotic bone, like this one, 92-year-old lady, ADL independent, very comminuted, shattered. The arm is in a lot of pain. So we discussed 92. I mean, should we really operate? I'm sure there is a lot of controversy. Again, we can treat it non-operatively. MIPO is always, used to be our first choice, and also nailing. Again, we go for the nailing, thinking it's more minimally invasive. There are the fragments, we try to bring it closer together. I have another talk on the fracture gap healing. That's why we try to close up the fracture fragments using minimally invasive manner. And again, produces rather amazing result. I try to take a picture and then I have to remind myself, why do I write down 3 weeks? Because I was so amazed that 3 weeks time, the patient have no pain and can do all sorts of activity, minimally invasive scars over that area. And at 2 months time, the fracture united quite uneventfully. How about the more common to the three-part fractures that's been discussed? Again, similar to cases like this, you have this is a real indicated for surgery with a displaced fracture, 68-year-old lady with good past health. Again, similar to the case presented, you can choose a plating or you can choose a nailing. I mean, in the past, again, we go for the nailing, plating, but now we have a more medial position of the implant. Again, you can't go through the nail, go through here. If you go through here, you have some bone to hold the head. So this was the result, and as you can see, I mean, again, you have to start off with the simpler cases, and because it is, you have to spend time. You have to spend time to find the entry hole. The common pitfall is that you still have a very lateral entry point, and you have a very anterior, because of the acromion is blocking, you tend to have a very lateral and anterior entry point, and that's wrong, okay? So you have to use your joystick technique to tilt the head into a more valgus position, find a more medial entry point, more or less similar, almost near the AC joint region, not at the tip of the acromion, more or less over the AC joint region. And then over there, you make the cut, and then it's important to extend the arm so that you get a more central entry point. And as you can see, the patient have good healing and good shoulder function afterwards. Again, this is another 63-year-old patient who doesn't want a lot of scarring. She strongly requests so-called small scar surgery, and that's why, again, we go for the straight nailing. Another beauty is that sometimes when we open up, you do see rotator cuff tear, particularly in patients older than 50 or 60 years old, commonly find rotator cuff injuries, and you can actually do some kind of a repair for that. The entry point, again, is the central. It's very important the tuberosities are all fixed with the sutures first before you can do it. And then the reduction of the humeral head, reduction is always the most important part, no matter you do a MIPO or the nailing, okay? Put the head into valgus by using this joystick technique, and then you can choose, okay? You insert the first one, you can also tilt the head into a more valgus position, and insert another one, putting it in a more center position. And again, we put it in a similar position as the Tirachar has shown you, and then you can find it on the lateral view, more central position on it, okay? And insert this stop wire. Again, this patient and other patients have a full thickness supraspinatus tear, and then people can do a repair. Small scars as shown in this one. Similarly, 90-year-old patients having very good results, although, as you can see, the head is very, very osteoporotic. So as for the rehab, again, it's the arm's length for 4 weeks. Early passive and assisted active exercise, very similar to a MIPO, and then active exercise at 4 to 6 weeks' time, and strengthening when the fracture starts to heal. So in summary, I think I hope I've been able to show you that the newer design is really promising of the straight nail. It holds the bone in a central position. Again, you have to rely on the sutures to hold the tuberosities. It is very important to reduce the neck adequately, put it in a valgus position with the K-wires technique that I've shown you, so that you get a good entry point. And again, I mean, there is an advantage of repairing the rotator cuff. Thank you very much for your attention.